Good afternoon. Thank you to the organizers for the chance to share some experiences regarding monitoring of family planning, the experience of PMA 2020. PMA is a performance monitoring and accountability project. So why monitoring and evaluation? I'm speaking to the converted, but I can quickly go through this quickly. First, I think it builds transparency and accountability, and my project is PMA 2020, meaning accountability component in it. We can generate information for decision making, and certainly we can guide programs based on the experiences of the current projects. I can summarize this slide with the last bullet here. Contraceptives save lives. And all the things you're doing, there are many benefits. For example, if the 120 new users, as per the Family Planning 2020 commitments, we would be able to save 100 million unintended pregnancies, would have 3 million fewer babies dying in the first year of life, would have 200,000 fewer women dying of pregnancy-related complications. Certainly, this is one way of saving lives. But more important also is that family planning is cost-effective. So there is a need for us to be able to track what's going on. So what is the objective of PMA 2020? The first thing is to monitor progress of the core family planning indicators, and particularly because government of Kenya, like many other countries, committed themselves to improve family planning from what it was in 2008-2009 to modern contraceptive prevalence rate of about 50%. And secondarily, we have other data on water and sanitation. One would ask, water and sanitation, what is the relationship with family planning? But this is in relation to menstrual hygiene management, and I will not go to those details. So this is the counties where we are implementing the activity in Kenya. In Kenya, we have 48 governments, 47 regional governments, and 1 central government. We are now in 11 of those counties, cutting across. And again, if you look at that location, which are sites based on proportional to household size, this is the area where you have the highest concentration of households. The northern part of Kenya, fewer, so is the lower part of Kenya. So what the PMA 2020 is based on a couple of things, and we do household survey, measuring demanded use, because we ask questions to women, but we also do ask question at service delivery point to measure supply and access, which are all very important elements. I'll not go into details there, but the point to note is that the project is within 11 countries. I do not see any country from South America, but it's across the spectrum, and therefore there's an opportunity to use this platform. I shall be concluding later to let you know, to monitor the things we intend to monitor under this network. So the main key advantages of this program is the fact that we can collect data with speed. I shall show you that in 6 weeks' time, we're able to generate 2-page reports. We can do it quite often. The first 2 years, we did around every 6 months. Now we're in the cycle of every year. The quality is quite reasonable. It is a flexible platform. We can add modules as needed. Affordability could be relative, but we feel that it is an affordable system. If it is institutionalized in countries as part of the routine data collection, then it's likely to be sustainable. And there's an opportunity for us to triangulate the information we get with survey statistics. So how does it work? It is based on what we call a resident enumerator. This is a young woman who says, in the area we are collecting data, is able to go to a household and ask women questions, 15 to 49 years, is able to go to a service delivery point with a just standard smartphone. I think everybody is here having a smartphone here. So with that smartphone, they are able to send the data to a central server. We are able to look at that data, do de-identification of the data, and be able to produce automated outputs, which then you're able to share with end users. So that cycle from the point of data collection to the point we have something for the end users takes about 8 weeks. So in 8 weeks' time, you can have some information to guide you. So the main advantage here with speed is we do not have this where you have collected data from the field, it are now stacked together, and you have data entry, because the data goes to the system automatically. Of course, there are challenges. You need to be meticulous about it. You need to monitor the data as it comes through to ensure that data is not missing from the system. As you realize, there can be system failure. So that helps. Important is that you can aggregate your data at different levels. If you want to do at a enumeration level, at the county level, at sub-regional level, even at the national level. So for Kenya and many other countries with PMA 2020, indeed we are able to either generate a point estimate for the national level or even at sub-national level. So this is what happens in your smartphone. This is basically the questionnaire which is programmed in the smartphone. We are using Open Data Kit, open software, but there are many other platforms one can use. So with this, then one is able to train the individual to collect this data from the households. Of course, the limitation here is that open-ended questions will not be very difficult to collect data using this particular platform. So this is what happens. The phone has a GPS. We are able to say this is exactly where you are, and this is important for us to monitor the resident enumerators as they collect data. We do have a date and time stamp, so we can tell you exactly how long does it take to do these interviews, and of course to avoid people doing the things under the tree and giving information. We do correct pictures of the entrance to the household for purposes of spot check and verification. And this is the process, and we are able to use that information to make sure that we have solid, high-quality data. In the different countries, this is where we are in terms of data collection. Many countries have different number of enumeration areas. In Kenya now we have 156, and they're in different levels of data collection. The importance of this slide is to note that there is a wealth of data, and I think some of the network objectives of training, there's certainly a wealth of data which can be available for purpose of training. So what is the design? I've mentioned that we do have a resident enumerator. Why resident? Because we are collecting data on a regular basis on a 5-year period. We have enumeration areas which are selected by the statistical bureaus in the respective countries. For every enumeration area, we visit about 42 households. We expect the yield is somewhere between 0.8 and 0.9, meaning we interview about 35 to 40 women, and in some places we do get exactly 42 women. The age range is the standard for demographic and health survey, 15 to 49 years, and we select service delivery points which are within the enumeration area, as well as public service delivery points which then serve the particular EAs. So this is a questionnaire we have. We have a household questionnaire where we are able to restore the members of the household. We are able to identify women who are 15 to 49, and of course that's the group of women we interview, and we do interview service delivery points. The important point to note is that the questions were rifted, most of them nearly 90% without modification from demographic and health survey, and that allows comparability of the data with the demographic and health survey. I mentioned that in the first 2 years for all the countries, the data was collected every 6 months. For Kenya right now, my team is in the field. We are in year 3 of the project, and we are collecting data for round 5. And thereafter, we'll be collecting data every year. So these are the key indicators. Again, we do collect from the field. And this, again, can be very easily linked with the objective of the network. Some of the results from our previous studies, we note that the Kenya Demographic and Health Survey was done when we were doing round 2 of our data, and our point estimates were very similar to Kenya Demographic and Health Survey. Our round 1 data had produced estimates which at that point were too good to be true. But the good thing is that at round 2, our data was confirmed by the DHS. And this is a trajectory we are seeing. For example, we are seeing unmet need for family planning decreasing, which is consistent with the fact that we see the modern contraceptive prevalence rate going up. But also important is that the efforts being put in Kenya seems to be bearing fruit in the fact that the total demand is satisfied by modern methods of contraception. These are some of the key indicators for the different counties. Again, looking at different counties, data from PMA 2020. Fertility indicators. One of the things we are examining and we are taking time to think about it is the unintended pregnancies. We see that in Kenyan context, about 40% of the women still have unintended pregnancies, either for not wanted at all or wanted later. And this is a concern for us because we see the modern contraceptive prevalence rate is going up, but yet is not in the same magnitude in terms of decrease of unintended pregnancies. We also look at the data depending on the wealth quintile, and we have questions which are able to look at that. We see that the lowest wealth quintile, they have much more unmet need, but again, the demand satisfied is improving, but of course, the lowest wealth quintile, their demand is only 75%, 74% satisfied compared to the 86% in terms of wealthiest. So there are improvement in Kenya, but we still see that there are things which need to be done. Our data is able to give us method mix by the different categories of people, and we see there are changes in method mix here. For example, the injectables is now 46%, and it was 52% before. So again, we are able to monitor these things on a real-time basis. And this is for unmarried women. Of course, it's very clearly different. If you look at unmarried women, emergency contraception is a major method of choice, while if you look at the married women, the difference is very clear. So we are able to give information on all these indicators of access, equity, quality, and choice. And these are the indicators we use to measure some of the elements there. For example, did you receive a method from public facility? Were you counseled on side effects? Were you told of other methods? Do you pay for services? Was a method chosen by yourself or jointly with others? And all these are important in terms of family planning programs. I will not go into these details, but I mentioned we do correct information on water and sanitation, but the point is that we look at that in terms of menstrual hygiene specifically. So in conclusion, we see that PMA 2020 is a robust platform which is able to generate reliable data, and that data is important for programming, training, but as well as having another set of data which you can triangulate with service statistics data. For example, Kenya and the East African region, we are implementing District Health Information System 2, and we have taken our data trying to understand are the patterns we are seeing from the community similar to what is being reported in routine data. And that is concurrence or this correspondence of that data, which is very satisfying. Meaning that if you're able now to support routine data correction, then these other external surveys over time may not be very necessary. I've shown that there is rapid turnaround time. We can produce reports very quickly. We can be able to link the facility with the community data. We are able to generate point estimates, which are very close to the gold standard. And I say gold standard here because there's a demographic and health survey, but of course that can be debatable. And we have a lot of countries involved. And my last is to acknowledge all the different partners. This work in Kenya is led by the Ministry of Health. National Council for Population and Development is a custodian of population management matters, and they lead the process. Kenya National Bureau of Statistics is the institution with the mandate to run surveys and research in Kenya, and they are involved. ICRH is the institution implementing this activity with funding coming from Bill and Melinda Gates Foundation through the Bill and Melinda Gates Institute of Population Studies at Johns Hopkins University. And for more information, I invite you to visit these locations where you can find more data regarding PMA 2020. Thank you very much.